So I am very pleased to introduce the chair of this session, Dr. Naoko Yamamoto, who is the Assistant Secretary General at the WHO responsible for universal health coverage. So we are extremely honored that you have been able to come for this to this conference and particularly to chair this panel. Dr. Yamamoto is a medical doctor who is one of these overqualified ladies who has several other degrees in public health as well. And she was Vice Minister for Health of the government of Japan prior to joining the WHO. So, please. Yes, yes. Very well.
Okay, good morning. Good morning. Oh, thank you very much to inviting me here. I'm very honored to come here. And unfortunately, I missed yesterday's wonderful discussion about this challenging topic. And also, I missed the reception as well. But I try to catch up, and I'm very looking forward to discuss with you about politics and inequality or equality and health, universal health coverage. And it's a core agenda for us as a WHO as well. So, but before to start this session title is Public or Private Financing for UHC, the consequences for health equity. So private or public, the financing issues, but perhaps one of the our most strongest message about the health financing issues is UHC is the most important of the public financing or public funding. And yes, we will look at the health system, which has performed well in UHC context. We should agree on resilient public funding as playing a critical role, I think. But at the same time, because of the financial constraints, many countries rely on the private funding, including out-of-pocket payment, or sometimes private insurance, health insurance system. So the message is clear, but how we could encourage the policymakers to decide to some correct decision, or what's the meaning of the public sector's funding and the private sector's funding as well. How to complement each other, or how to manage the private sector's funding well. So we have a lot of questions and also challenges, but at the same time, a good example, a good experience. So I'm really looking forward to discuss about this with wonderful four panelists. Honestly, several people, especially Ikegami sensei, is my teacher, so I'm so nervous about the chair to my teacher, but I hope he will not give me some C grade, so I hope free. But we have a wonderful panelists. First, Robert Yates, my dear friend, from Chatham House, and Anna Marriott from Oxfam, we met this morning. And now Ikegami Naoki sensei, we call my Japanese sensei means like a respects person, but Ikegami sensei, now St. Luca International University. And we have Susan Erikson, Simon Foster University. So we have four people. This is Chatham House style to sit together, or each person can present. Okay, and after that we have a question discussion. So first, I would like to invite Robert, Chatham House.
and gentlemen, and thank you so much for inviting me to this conference. I'm a political health economist based at Chatham House in London. I also work for the Elders. So the politics of health coverage is very much my favourite topic. So to have 2 days just talking about this is a real treat for me. I want to talk today about the politics of health financing. And really not just to be studying the politics of health financing, but just like David McCoy was saying yesterday, really encouraging people to get involved in the politics of health financing, because really this is how we're going to bring about change. So, first of all, looking at universal health coverage, and go back to the definition. And now, of course, I know that everyone here knows what universal health coverage is, but it is important to go back to the definition because it really does lead to some profound policy implications for the financing. So what is the definition of universal health coverage? Is all people receive the quality health services they need without suffering financial hardship. It's quite a simple definition, but from that, there is really quite profound what it means. Because really, UHC is all about equity and fairness. And it's pretty obvious, you know, the universality aspect of it. Everyone on the planet, everyone, you know, all citizens, but also all migrants, everyone on planet Earth should be getting universal health coverage. Nobody should be left behind. It's one of the mantras of the Sustainable Development Goal. We're talking about health services allocated according to need. And objectively, some people need more health services than others. Pregnant women and children, elderly people, people with chronic diseases, they need more healthcare, they should get more healthcare. Also, from the aspect that no one should be left behind, everyone should have access to this, it's logical that you need a health system that's financed according to people's ability to pay. That richer people pay more than poorer people. I mean, otherwise you just don't have, you know, that financial protection. Now, if you combine those aspects, really what we're talking about is a health financing system where the healthy, wealthy cross-subsidise services for the sick and the poor. That's what UHC, a lot of it is about. And I want to dwell a bit on the financing. Of course, we need to consider all the other health systems. And, you know, this isn't to neglect human resources and medicines and information systems and what have you. But the financing is absolutely pivotal. If you don't get the financing right, you can forget universal health coverage. And what we're learning, and Naoko was mentioning this, and there is this emerging global consensus that I think WHO really crystallized brilliantly in the 2010 World Health Report that basically says that you've got to publicly finance your health system if you want to achieve UHC. Because we know that a market-driven health financing system, when people buy and sell health services like they sort of buy restaurant meals, will never, ever achieve universal health coverage. And one's only got to look at the United States to see that, you know, sort of a system which is, there's a large element of private transactions will never reach universal health coverage. And really that's because you need the state to force healthy, wealthy people to cross-subsidise the sick and the poor. Left to their own devices, they won't do that. There might be some charitable giving and some bake sales and stuff like that, you know, to sort of pay for things. But at the end of the day, that doesn't pay for heart transplants for poor people. And you need the state to force people. So the state has to be involved in all the key functions of a health financing system. How the money's raised, who pays what, how it's then pooled into sort of, you know, a great big sort of pot of funds, and then also how those funds are allocated over different services. And really what we're talking about is the transition to universal health coverage being about replacing private voluntary health financing, user fees, private insurance as well, with compulsory public financing. Now, that transition is inherently political because, not surprisingly, there are many interest groups who don't want that. They don't want to subsidise the rest of the population. They prefer just to cover their own health care. And it's very, very important that we get stuck into the politics of this. Now, this is a graph actually inspired by WHO, which sort of plots the transition to UHC. So at the bottom, you've got public spending as a share of GDP. And on the vertical axis, you've got out-of-pocket spending as a share of total health expenditure. And so countries that we associate with universal health coverage, New Zealand, Japan, Australia, now they're wealthier countries, they're spending relatively high amounts of public spending as a share of GDP. And as you can see, that has the impact. It takes the financial burden off the populations through out-of-pocket expenditure. And at the top, I'd say that, the countries in Asia that have got most progress to make in reaching UHC. And so it's all about that crowding out that. Now, what's interesting about the transition to UHC is that countries don't gradually slide down that curve. Sort of what tends to happen, you get big jumps. When at some point a decision is made to put in a lot of public spending, specifically to sort of try and get rid of the financial burden on the households. And this very much marks the transition to UHC when you make that big step. And that step is made by political leaders. To make that decision that you're going to put 0.5%, 1% of GDP into your health system is a head of state issue. And so we need to be thinking about promoting UHC to political leaders. It's essential that you get that buy-in at the head of state level, because it's very unusual Minister of Finance who will suddenly say, oh, yes, let's double the health budget. Why didn't we think of this before? We should be spending a lot more money on health. As a general rule, economists and ministers of finance don't like health sectors. I think we have to be honest. They prefer to spend money on often infrastructure and trade-related things. They need to be persuaded, and that's when you need the head of state. Now, what we should be really thinking about is, okay, if we are thinking about pitching it to the head of states, what's the pitch to them? What interests a president or a prospective president? And really what they want is power. Now, it's almost a dirty word, isn't it? So, you imagine this sort of power-crazy head of state. But politicians want power, many of them, to do good things. This is what they need to be in power to implement pro-poor policies, not only in health, but in other areas as well. So we should be selling them this idea that, that we can give you what you want. And UHC is a very smart thing for good politicians to do, because it's something that everyone on the planet, I would suggest, wants. They want health services. They don't want to be bankrupt as a result. And it's very easy to explain to people about the benefits of this. It's just an obvious thing to say to the population. Also, what we've seen, and I've alluded to this already, you can get results very quickly. You can reach the entire population. In the case of the UK, we know on July the 5th, 1948, we launched our National Health Service, and all of a sudden, all the health services were free for everyone. And it could be done on one particular day. It's very unusual to have a social policy, any policy, that benefits the population so dramatically. And so, the equation should be saying to the politician is there's votes in this, there's power in this, so it's in your self-interest to do this. And as David was saying yesterday, we need to be thinking about alliances. Who influences heads of state and politicians? CSOs, trades unions, use the media, thinking creatively, often about sort of maybe bypassing the Ministry of Finance and, sort of the rest of the cabinet. How do you get to the person who really matters? And obviously, thinking about when's the best time to do this. Often, in the run-up into elections, it's a pretty good time to catch politicians' attention. And I just want to sort of illustrate now, in a sort of series of slides, sort of people who have done this, and to illustrate that not only is this a good thing to do for sort of the population, but really the pitch to political leaders is if you do this, not only might you stay in power, you might become a national hero. You will go down in history as the person who made the transition in your country. And so here we have, I'm not sure if we've got any Canadians in the room. I think we have, yeah. Tommy Douglas, voted the greatest Canadian of all time because he first brought UHC to Saskatchewan and then rolled it out on a national level. You've got Nye Bevan, who's the architect of the NHS, on the very day, this has become a very famous photo. It's almost sort of biblical, this sort of, sort of picture of, laying of hands, sort of that. But I mean, he is venerated in the UK for having brought us universal health coverage. Thaksin in Thailand, sort of brought in UHC in 2001, very much against the advice of the World Bank. But he decided he was going to go for it, and it's heralded as one of the great health systems in Asia now, sort of having done this. This is the then governor of Jakarta, Jokowi. Within a month of coming to power, he was launching UHC to the population of Jakarta, giving people these free health cards. And it was massively popular, and I happened to be living in Indonesia at the time. His popularity just shot up, and he was being courted as a presidential candidate. And then in the presidential debate on television, he whips out this card and then basically says, I'm going to bring to the population of Indonesia what I've done in Jakarta. And was really instrumental in him now being the president of Indonesia. India is fascinating at the moment. You can see that India is, sort of moving in these directions. This is the Prime Minister Modi, who just in July launched what's being called Modi Care. And it's supposedly covering 500 million people in a blaze of publicity. He's got this idea that UHC, there's votes in this. Now, it's very political in India because we haven't got time to go into the details, that the focus is very much on hospital care with his reforms. But in Delhi, you've got the Delhi state government promoting a primary healthcare driven approach. And here is the former Norwegian Prime Minister, actually, I'm sure a number of you recognize Gro Brundtland, in a Mahala clinic talking about a different strategy to UHC in India. And there's an almighty political battle going on about this at the moment. The United States is the country to watch on this at the moment. I know that you might find this sort of surprising. Obama obviously sort of took some big steps towards UHC, but then, he wasn't able to sort of carry through what he'd really like to do. But what you're seeing now is sort of the more sort of left-wing parts of the Democratic Party promoting UHC as a great thing for the United States to do. And in California, the governor is running on this ticket, or there's going to be a governor election on Tuesday, and watch out for Gavin Newsom, who is promising to bring UHC to California. And this just shows that these are the latest betting odds on who's going to take on Trump in 2020. And I've just sort of shown that 4 out of 6 are promoting UHC, single-payer UHC in the United States. Now, Dr. Tedros is sort of recognizing that, this is a very sensible thing to do, to be talking to politicians about UHC. And so he's been to Kenya, sort of talked to President Kenyatta, who announced UHC reforms. And just a couple more slides. Nigeria is another country. Elections coming up next year. Is President Buhari going to run on a UHC ticket? We don't know. So finally, the point being that UHC is mostly a political issue, I would suggest, particularly introducing an equitable public financing system. UHC is popular with people and politicians all over the world. And the beauty of it is it brings politics into health systems, and this is what we desperately need. But we must get better at engaging in the politics. We often dive under the table when people start talking about political things, and that's a big mistake. So what we should be doing is promoting the economic benefits of UHC to the financiers, but if anything, our best trick is to promote the political benefits to the political leaders, and then we'll get the financing we need. Thank you.
And then now I would like to introduce invite Naoki Ikegami sensei, because he's my teacher, so I say a few words. You may know that Japan introduced a so-called universal health coverage 1961, I think. And our country is very domestic, but he is one of the person who opened the door and invite Japanese people to join the international arena to discuss about UHC. So, Ikegami sensei, please.
Well, thank you very much for the introduction. So I'm a professor, so I start by one of my lectures. And there are three objectives in healthcare policy. First is not bankrupt the patient, because healthcare costs are the leading cause of poverty, and quality should be guaranteed to all patients. Well, if quality is to be guaranteed to all patients, the government must pay. But so the second objective is not to bankrupt the government. Healthcare costs must be controlled by the budget. And costs must be contained within the amount that the rich, who must pay a large share, will agree to pay. In order to do so, the third is to manage the expectations of patients and physicians, set appropriate quality level, and set appropriate income levels of physicians. We talk about costs, but it's actually about how much do you want to be paid for. So the first, not bankrupt the patient. How to prevent the patient from becoming bankrupt as a result of healthcare costs cannot be left to the patient. In a life or death situation, prepare to pay any price going to bed, and patients are not prudent consumers. They cannot rely on physicians. We advise patients to choose the best, especially if they get paid. So this means it must be publicly financed and not privately, and restrict out-of-pocket payment and private insurance. Well, out-of-pocket payment is two parts. One is a co-payment for publicly financed services, a fixed amount per visit. And this is object lies in containing the patient demands, because if it's free, there's a fear they will use without balance. But there's also what is called euphemistically topping up. This is extra bill for services and drugs not publicly available, or balance bill with a surcharge. And it's very difficult to control individual transactions, because that's what ultimately healthcare is about. So what to allow? New drugs still being tested, private rooms, treatment by renowned physicians. What would be the ideal private health insurance? It will be the low premiums, generous benefits. Now, how to achieve this is to enroll those who are healthy and at low risk, and exclude the chronically ill. So this means that the high-risk chronically ill will be thrust on the public system. So for equity reasons, private health insurance must be regulated and restricted. It should not be a supplement public insurance, but complement. The benefits could cover private rooms and treatment by renowned physicians, because to be treated by Professor X would have value in itself, regardless of whether it produced better outcomes or not. So how does Japan tackle this problem? On face, it seems a very difficult situation to cover, because for health insurance plans, we have over 3,000 plans, because each industry, like Toyota, Sony, has its own insurance plan. Each community, like the city of Oslo, has its own insurance plans. And there's over 1,500 municipalities in Japan. On the right side, the providers are private sector dominated. 80% of the hospitals are privately owned, mostly by doctors. And physicians' offices, the clinics, they are 95%. So how does the government control costs and control quality? It is by the single payment. We call it a fee schedule. It defines benefits, the drugs that are available, the surgical operations which are reimbursed, and it sets the price and conditions for billing. Now, I emphasize the conditions of billing, because only if the hospital meets certain standards, or if the doctor meets certain standards, they are allowed to bill. And so by tightening or loosening the conditions of billing, it effectively controls the quantity, not only the cost. And furthermore, 90% plus of the provider's revenue from services delivered at the prices set by the fee schedule. That means less than 10% from private rooms for services outside of health insurance, publicly covered health insurance. So the first objective, not bankrupt the patients, is met by the patients pay 30% of the total as a general rule. However, elders and children have reduced rates of co-payments exceeding the ceiling. The patients pay only 1%. So what the United States, this is called the catastrophic coverage. Any out-of-pocket amount that is above a certain amount that is slided according to income, the co-payment is reduced to 1%. There are also strict restrictions on topping up. Extra billing generally limited to new technology being developed in approved hospitals, and balance billing generally limited to extra charge beds. Other than this, topping up is strictly prohibited. The second objective, not bankrupt the government. And this is something that is rarely mentioned, but I think is crucial if we are going to convince the financing authority, is to control total healthcare costs by the budget. And this is achieved in Japan, despite the private sector dominated providers and fee-for-service payment. Fee-for-service means basically one injection, $10, one consultation treatment, $15, and so forth. So it's an item-by-item addition for the billing process. And this has come about because 80% of the hospitals are in the private sectors, and providers bill for each item delivered to patients. It is not a global budget. The hospital is paid for every service, itemized service it provides. And so health expenditure is fee times the volume of each item. So the fee schedule not only sets the fee, but also the volume of each item by the conditions of billing. The first for example, this is very explicit and very complicated. The first consultation fee can only be billed if the patient had not made a visit in the past 29 days. Why should this be so complicated? This is because the first consultation time takes much more than the repeat consultation. So therefore, the first consultation fee is 4 times the amount of a repeat consultation fee. To prevent doctors from billing every patient visit as the first consultation visit, these are very specific rules that are laid down. And if they do not obey this rule, they pay a penalty. They have to pay back. And if it's done very explicitly, then they may lose a license. So the second is revising the fee schedule. Fees and drug prices are revised every 2 years. The process starts by setting the global budget. The global budget is set by the global revision rate, the volume-weighted revision rate of all items. At the growth, how much does the budget amount, the expenditure amount to? Each fee is adjusted up or down. The volume is contracted or expanded according to the conditions of billing. So once the global budget is set, then the fees and conditions of billing are revised on an item-by-item basis. Not across the board. This was once tried in Germany, and it failed. Because if you do it across the board, all the providers will be united in opposing such a reduction. But this is, according to the British colonial policy, divide and rule. Some fees go up, others go down, some conditions tightened, others loosened. Government has data on the volume of every service delivered. How much electrocardiograms, what is the volume? So if adjusting the volume, the conditions, and the fee, it can set the total amount. This is in all the third world countries I visited, they all have MRIs, but this is what was done to reduce MRI scan fees. In 2002 fee schedule revision, they were reduced by 30%. And the reason why they were reduced by 30%, because the global budget, global revision rate was set at -2%. We cannot reduce consultation fees by 2%. It will be very politically difficult. But we can reduce MRI scan fees because MRIs have become less expensive. They are more popular, and the manufacturers were willing to give big discounts to hospitals because they competed to sell the MRIs. But these regulations must be strictly enforced. The claims, that is the bill from providers, how much for each patient, each item was delivered, they are reviewed for adherence to the conditions of billing. The reviewers are senior physicians who are employed about 5 afternoons per week and paid $2,000 per month. I mean, you have to pay doctors to get good service, and they are paid to go through the claims and see this lab test has been excessive, this drug should not be used, and based on the diagnosis and the hospital's reputation. So although the claims denied compose only 1.4%, it has a very significant effect. And there are also on-site audits. This is to match claims with medical records. If not documented in the patient records, the facility must self-audit the claims submitted in the past 6 to 12 months and pay back the amount if inappropriately billed. If purposeful, both the doctor and the facility will lose their license, and this means shutting down the hospital. So how do we get the act together? That is managing the expectations. Health service delivery is relatively stable. Physicians deliver services based on their experience. Patients' expectations are based on their experience. In Japan, if you have a persistent headache, you would expect both the patient and the doctor to have a CT scan, perhaps not in the NHS, but in Japan, that is a norm. And the most important part is half of all healthcare expenditure is labor. So when we talk about healthcare expenditures, we mean physicians and nurses' income. So when providers say cost, they mean income. How much does it cost? How much should I be paid? And relative cost income is critical. So this is about how much doctors are proportionally paid in Japan. They're 3 times as much as nurses and slightly more than office workers. In Norway, doctors are paid less, relatively. And another important aspect is due to the political power within the medical profession, the primary care physicians are paid more. You see on the right side, the primary care physician making a home visit, he is paid about at least 1.5 times more than the specialist you see on the left side, because that is how our fee schedule is constructed. So there's institutionalized negotiations. Government cannot unilaterally dictate terms to physicians and hospitals. Decisions on resource allocations are made by physicians who have professional autonomy. You cannot order doctors, you can only nudge doctors. So a formal process of negotiation is needed. Physicians and hospitals must organize themselves. In the countries I visit, they are very disorganized. So it may seem not against the interest, but it is better to talk with one association than talking to 1,000 doctors. So they must be encouraged to organize themselves, and the government must establish an organized structure in order to continue this negotiation. The media, political parties, and civil societies must represent the public, because the patient is powerless. To summarize, the goal of UHC is not just about population coverage. If you issue the insurance card, that is very easy. What does that card get you? That is the financial protection of the patient. And to achieve this goal, public financing is essential. Topping up must be strictly regulated. Physicians and healthcare workers must focus on providing services in the publicly financed sector. Payment must be well designed and revised. I emphasize the need for revision. The fee schedule you cannot set in perpetuity. It must be always revised. And finally, the expectations of physicians and patients must be managed. Thank you for your attention.
Some questions? Oh, because I have also bigger questions, but I expected several questions. So, lady from first. And please identify yourself and the question, please.
Hi, Ted Schrecker from Newcastle University. As a Canadian now working in the UK, I was delighted to see Tommy Douglas and Nye Bevan featured prominently in Rob's presentation. But as a political reality check, I think we need to note that the NHS is now under sustained and disingenuous attack from the right in the UK. The director of my unit, Alison Pollock, is one of the leaders in pointing that out. And that the national political party Tommy Douglas went on to lead in Canada was actively investigated and probably infiltrated by the federal police until well into the 1970s. Not everyone loves these people.
Thank you very much in comment. So I would take some floor. This one, the lady, yes, please.
Hello, my name is Jessica Gao, and I'm actually not affiliated with any university or institution. I'm just here out of interest for the conference and the topic. So here's my question. I was wondering, what are your thoughts and comments and suggestions maybe on the countries where they don't have the culture nor mostly the culture of UHC. For example, in your presentation, Mr. Yates, you mentioned about several countries, and you said that the political leaders have an important role to play and how UHC could appeal to get votes. What if the leader has been there for a long time? And such as, for example, on your graph, there's Cambodia, which was at the top, where people really have to pay out of their pocket. And Hun Sen, the prime minister, is one of the longest serving leaders in the world. So what if there are no incentives for him to get votes? So what happens in that case? And for example, in your presentation, Mrs. Marriott, you said that there are results on how in, I don't remember whether it was Kenya or Africa, but where there are mostly investments in high-end and luxurious hospitals. So what would be the incentives, for example, because to invest somewhere else, because that's where the money goes, that's where the rich people with money go. So why would they invest anywhere else than the rich hospital for the rich people? You know, it's not in their culture.
Thank you very much.
Yeah.
I would like to take some couple of questions and comments, and I ask the speakers to pick up some questions, but I would like to ask you to crystallize your questions and comments because of time. So the back side, the ladies.
Hi, I'm Sanya Reed-Smith from Third World Network. That was a very interesting series of presentations. Do you know of any countries, I don't know in Japan or otherwise, where governments may say that hospitals must be not-for-profit or other healthcare services must be not-for-profit as a kind of legal requirement? And the reason I ask this is because in trade agreements, if you commit to liberalised services, you cannot specify that they must be not-for-profit unless you put an exception. And that may be positive list in the WTO or negative list in certain free trade agreements. And so governments have to remember that if they want to preserve the ability to have not-for-profit services, that they can't give it away in these trade agreements.
Okay. Thank you. I would like to take a couple more questions, comments. As the gentleman on the side.
Hi, I'm Edwin Meso. I'm in Universal Health for African project with Ruth Prince. And I'm a PhD student in Aarhus and Oslo. my first question goes to Yates, and thank you for the presentation. But my understanding is that when you equated universal healthcare to votes, my fear is we are trying to dangle a carrot to a politician with various ambitions, and probably in one way or the other, are we now having to redirect the political agendas of a given nation and sovereignty being put into question? Then secondly, I think to Professor, I kind of forgot your name, but kindly, there was a question, you talked about having disorganized system in developing countries or other countries, and and the need maybe to talk to organized groupings, and there is always the issue of cooptation of these groupings, whereby the agenda is sometimes driven by state entities and their leaders are always put into question based on their agendas. So my question is, as much as we talk about these organized systems that need to be utilized, what about when we have these systems put into question? How do we maneuver against that rubric? Thank you.
Okay, thank you. Is there any other comment, questions of the gentleman here?
Thank you. My name is Aris from University of Oslo. I have questions about universal healthcare and public-private funding on this. How do we exactly monitor the progress? Because I think in one of the presentation it was mentioned that there is a need from the patients themselves, there is a need from the government not to be bankrupt because of the universal healthcare, and also there is a need to achieve the common goal for both of the patients and the healthcare providers. And should that be a standard monitoring tools that we can work with the countries that implement universal healthcare? Do they achieve this after a certain period of times, or or which part of the components that they still need to achieve? And I think there is a need also to look. I like the idea of asking to the taxi drivers, because that exactly what I do when I come back to my original country, Indonesia. I ask, how do you feel with the universal healthcare? Do you actually get the needs? Because there are other costs on top of the cost of paying fee for service, but also the cost of getting to the healthcare service provider themselves. And do they really get what they need? Because it doesn't make sense if you need a prolonged medication for hypertension and you only get, for example, only for 1 week and need to come back.
Okay, thank you very much. I have another two gentlemen, the ladies front. So let me finish the two comments and ask the speakers to pick up some most favorite or most important. Okay,
I'm Johan Dahlström from SITE, the Swedish Institute for Global Health Transformation. And I would just like to say that I believe very central is the term universal. I worked for 12 years with implementation of ODA, and one thing I missed was the story from the country where I come, which is Sweden and the Nordics, which is that ODA was very much, the projects and programs I worked with had a very strong focus on marginalized groups. And when you have that, actually you miss out a lot of the story, the narrative of society, which is actually that everyone from the rich to the poor feels part of the same society. And I think that's a very important lesson and something that actually development sector has missed totally. We at SITE are at the moment working on some kind of Lancet site commission where we're actually talking about peace through health. And that's very much part of that story, to build actually the feeling among people in society that we're part of one. So I just want to state that. Yes.
Thank you. And the final question.
Thank you. My name is Salima from Uganda. My question goes to Anna. We see a trend where now, especially many African countries are being pushed to take on public-private partnerships with the argument that the public health system has failed. And I would want you to share some of your experiences. Is there any evidence to show that actually the public system has failed and PPPs are the way to go?
Thank you very much. So maybe, can I ask start off?
Yeah. Thanks. I maybe sort of deal with the more obviously political questions, and this question about are we sort of interfering in people in sort of democratic processes, I suppose, in countries. I think survey after survey across the world shows that access to healthcare, people wanting universal health coverage, really is universal. I mean, right throughout Africa, very, very high when asking poor people about, you know, what they want. You know, they want to be protected from healthcare costs. This was certainly true in Uganda, where a participatory poverty assessment, it was a bubble in one of the sort of the quote bubbles from, you know, a poor person said, cost sharing is not for poor people, you know, user fees are not for poor people, which was brought to the attention of the president, and who then duly abolished healthcare user fees. So you can see that it really is this groundswell of people wanting this across the world. The majority of Americans, 70% of Americans now want a single-payer health system, latest research is showing. So I think that we are on pretty strong ground, you know, showing that this is what people want right across the world. What's letting them down are their political elites not meeting their expectations. And you're right, we have to, you know, recognize that there are some leaders who just aren't interested in this and, you know, sort of year after year just neglect this. And this is where we need to be bolder, we need to be braver, and, you know, we as Global Health need to be working with opposition politicians, overtly working with them, supporting them, helping them. We're doing quite a lot of work with the AAP government in Delhi at the moment, sort of supporting their reforms. This is quite controversial, but the Modi government are trying to shut down their Mahala Clinics program, and this is wrong. And, you know, I think, you know, more global organizations should be supporting the sort of people who are advocating for a more universal approach. And just to come to your final point there, and I think one of the cells is exactly this, you know, that it helps build social solidarity. It helps people feel sort of happier in their societies. And the birth of the NHS in the UK was really about rebuilding the country after the war. And when Nye Bevan wrote about the success of the NHS, he called his pamphlet "In Place of Fear," would remove the fear of medical impoverishment from the entire population. And everyone felt great about that, the rich, the middle classes, and the poor. So these are the cells, but I do think that we need to be getting smarter in dealing with opposition politicians, particularly where leaders aren't interested in UHC.
I would like just to speak from the Japanese experience, and the distinction should be made between financing and delivery. And the private sector has a role in the delivery of care, and to ensure that the privately delivered care is in line with the policy goal, that is where the payment comes in. If the payment is made within the global budget and is focused on the government priorities, it would be an efficient way of delivering healthcare through the private sector. And that payment aspect, the fact it has not been controlled in the way Japan has made it, has given it a bad name. But at least it can be controlled, and it has been controlled in Japan by the government, the payment. So how much to pay for the itemized services, and to weigh the payment according to the policy goals and to contain costs. And to answer the question of how to organize the providers, and the organizers, it should be organized because in order to control payment, the provider side must be basically in line with the government goals. And in Japan, we have been fortunate because the fee schedule started in the 1920s when the private practitioners in primary care were the most dominant. And because it has been a political process, they have continued to be dominant. But the advice I can give to middle-income countries is to politically weigh the power to the private practitioners in primary care, so that they would be more influential than the specialists in tertiary hospitals. So that is to roll the dice so that within the provider group, those in the primary care field would have more voice than the tertiary specialist. And the tertiary specialist can be, part of their income can be raised by the private sector. So that's my answer. Thank you.
We have already passed the end, but let me take my advantage as a chair. I just say 3 issues. First, political commitment, as the lady said, that the UHC universal health coverage is under the SDG Sustainable Development Goal 3.8. The reason for 3.8 is at that time, the discussions, many countries doesn't want to talk about universal health coverage, but now 3.8. But now many political leader is going to talk about that issues, and even in Cambodia, the health minister is going to set the primary health care centers. As you may know that it's starting, and they're going to invite informal sector for the health insurance. So even still it's slow. So really would like to push ourselves together with the political leader to move ahead. Second is the monitoring issue and the marginalized people issues. Only one thing I should say that the UHC 2030 is a big global platform. All NGO and civil society is right now globally joined the initiative, and they are creating their own monitoring report. A couple of people will mention about the UHC monitoring report and data, but civil society is going to set together with us to make a monitoring report to focus on the marginalized people in terms of the universal health coverage. And then finally, PPP, private-public partnership. Again, time is limited, but a couple of good examples, like a public sector contract to private, clearly set a condition and ask the private sector to deliver services and so on. But that's a new initiative. But as Ikegami Sensei may say, that's not supplementary, should be complementary, or equal partnership is most important. It's a governance of the country is very important. So thank you very much. But regarding a PEF, I'm sure he said that PFA is, I need 1 hour more than 1 hour to talk with Susan, because the PEF is introduced the G7 presidency, Japan G7 presidency. At that time, actually, I was government and joined the designing the PEF together with World Bank, WHO, other world public health expert together with it. So, but I don't want to spend more time to, so let me ask everybody to 1 minute each to ask the next year, 2019, in the New York high-level panel, high-level meeting for UHC. It's a head of government is going to get together to New York and set some political declaration for UHC. So what is your expectation for New York? What you would like to ask the head of states to do, or say something, or declare something? It's a big question, and I really would like to ask you, all of you, about it, because just now we have heading the meeting and starting the preparation. So each people need to push your government to move ahead. So can I ask you? One word.
Well, I guess one thing I think would be great out of that meeting, it's not just a sort of great talking shop and everyone saying, rah, rah, we're doing UHC, aren't we doing really wonderfully? And I think what would be tremendous if civil society and people could call out governments that are patently not moving towards universal health coverage. I don't want to pick it out in particular, but Nigeria spends 0.6% of its GDP in public health spending. It's pretty much the lowest in the world. It's got a GDP per capita of $2,000 per capita, which is higher than Thailand's was when it introduced UHC. And I think some real honesty, sort of putting it to presidents, who are talking about UHC. And we can all take responsibility, global health as well, but putting pressure on governments to put their monies where their mouth is, and not just being a lot of platitudes that governments can just celebrate what they're not doing.
I really appreciate it. Wonderful speaker. Thank you.